Manami Ueshima, one of the pediatricians in Kameda Medical Center in Japan. Kameda Medical Center has been awarded as one of the world's best hospitals for the last 5 years. So I am happy if you keep the name in the back of your head, even if you forget my name right after the presentation, because I am the first presenter. I would like to go to the next, okay. Okay, so let's get started. First of all, okay, sorry, before that, I would like to show, I wanted to show the title, but okay, first of all, nephrotic syndrome is one of the common pediatric diseases that require glucocorticoid treatment. Patients with nephrotic syndrome might receive steroids for a long time if remission is not achieved. Evidence shows that long-term steroid use may induce osteoporosis in adults and children, and steroid use is well known to be related to avascular necrosis of the femoral head, ANFH, in adults. Patients with NS might receive steroids for a long time if remission is not achieved. However, there is no clear evidence regarding the relationship between steroid use and ANFH in young children without underlying conditions such as inflammatory, metabolic, hematologic, and bone disorders, including fracture histories, which means so far no pediatric case of ANFH caused by long-term steroid use due to NS has been reported. Legg-Calve-Perthes disease, LCPD, or sometimes just called Perthes disease, is an idiopathic ANFH in children, and its underlying causes are still unknown. In this presentation, I describe the case of Legg-Calve-Perthes disease following nephrotic syndrome with long-term steroid use in a 3-year-old boy. So here is the case. A 3-year-old Japanese boy with a history of nephrotic syndrome was brought to our hospital with the chief complaint of difficulty in walking since the morning. On the day of the presentation, he did not want his left upper thigh touched at home, and he had been crying incessantly since the morning. So it seems like something was wrong with his left leg. But other than that, every physical examination was showed he was fine. His birth history, including neonatal metabolic screening, was unremarkable, and his development has been normal. No relevant family history was noted. Vaccinations were up to date. He did not have a cold or a fever. He had no recurrent trauma or operation history. This is his past medical history. He was diagnosed with idiopathic nephrotic syndrome 1 year before the presentation. Although the amount of glucocorticoid intake per day had decreased slowly, he had been on oral prednisolone treatment for a year continuously without achieving complete remission. Thus far, he had taken over 3,000 milligrams of prednisolone, which means 230 milligrams per kilogram. The maximum amount of prednisolone per day was 30 milligrams, which was 2 milligrams per kilogram. It was considered to start using immunosuppressant. However, the family preferred continuing steroid medication at that time. On arrival at the hospital, his vital signs were stable without fever. His height and weight were within normal limits. On physical examination, no redness or swelling of his left upper thigh was observed. However, he refused to stand up and walk. Left thigh and hip joint pain on palpations were not evident. However, he tries not to bend his left hip joint. CBC, BNP, and other blood tests were unremarkable. Urine test shows an elevated protein level, and PC ratio was 0.73 gram per gram creatinine. The results show nephrotic syndrome was not recurrent, but did not achieve complete remission. So this is his pelvic X-ray scan. His pelvic X-ray scan shows asymmetrical femoral heads and thinning of the left femoral head. Can you see that? These are his pelvic MRI. His pelvic MRI revealed low intensity in the left femoral head on the T2 weighted image, and high and low mixed intensities in the left femoral head on the fat suppressed T2 weighted image. Thus, deformation of the left femoral head was suspected, and a small amount of synovial fluid was present. The epiphyseal nucleus of the right femoral head was also small for his age. So after getting the all of the examination results, he was diagnosed with LCPD, Perthes disease, with Castle grade 4 and Herring group C, which indicated a poor prognosis. These two severity classification methods are mainly used to estimate prognosis in this disease. Grade 4 in Castle classification means total epiphyseal and metaphyseal involvement. Group C in Herring classification means involvement of later pillar height more than 50%. So next, about the treatment. He was educated not to put his weight on his hips for a while, and he was then referred to an orthopedic clinic to begin rehabilitation with equipment to support his joint. These pictures are not showing a patient actually, but the images are like this. According to the disease classification, he may need surgery in the future, possibly like high possibility. I don't talk about the details of how the surgery performs here because I am not an ortho surgeon and it is not a main point here. Okay, now I'd like to move on to discussion. Chronic use of glucocorticoids for nephrotic syndrome is not rare in children because of recurrent relapse of the disease. Usually, we need to care about osteoporosis, not femoral head necrosis. Studies in children are limited. However, long-term steroid therapy may increase the risk of fractures in children. In particular, a study reported that pediatric patients receiving glucocorticoid therapy for more than 3 months should be cared for. In this case, the patient had received steroid for a year, and he had a higher risk of fractures than other children who had not received steroid. However, the relationship between ANFH, avascular necrosis of femoral head, and long-term or high steroid doses per day, or the total amount of steroid doses in children has not yet been concluded. As far as we know, no pediatric case of ANFH after receiving steroids due to NAS has been reported. Therefore, this is the first case report of LCPD in a pediatric patient receiving steroids for NAS. LCPD is a pediatric disease. Although its cause remain unknown, several theories propose environmental, metabolic, and genetic factors, like as I said before. Thus far, steroid use or NS has not been reported to cause ANFH, so this case can be categorized as LCPD, Perthes disease. A study reported a case of recurrent relapsing nephrotic syndrome after LCPD development was detected. However, the LCPD condition did not worsen after long-term use of steroid. The study concluded that steroids do not have adverse effects that can worsen LCPD. However, in this patient I present, LCPD developed after long-term glucocorticoid use for nephrotic syndrome. In addition, throughout his life, the patient has taken over 3,000 milligrams of steroids, which is substantial. Thus, in cases such as this, when the cause of ANFH cannot be confirmed, it can be related to steroid use. If so, we need to consider providing immunosuppressant-based treatment to reduce the amount of steroid use in recurrent relapsing NS more than ever before. It is also possible that nephrotic syndrome can cause ANFH because intravascular dehydration and loss of albumin in the blood due to NS can happen. Actually, it frequently happens. So there is no evidence, but we should consider the possibility too. In this case, the physician could not detect the LCPD until the patient started experiencing symptoms. And the patient might have a bad prognosis according to the disease classification. LCPD is difficult to diagnose because it can be asymptomatic in the early stage. Lameness and Trendelenburg gaits are common complaints during hospital visit, especially in young children, and pain is not always present. Therefore, its diagnosis can be delayed. The incidence of LCPD can vary from 0.4 to 29.0 children per 100,000 children. Although LCPD is an uncommon disease of hip joints in children, its early diagnosis and treatment are essential. Severe cases cause poor prognosis and affect lives tremendously. Children will have high risks for hip osteoarthritis developments in the future, and possibly they cannot walk in the future. Routine pelvic X-ray imaging might be recommended for follow-up on patients' hip joint, especially if the relationship between ANFH and steroid or nephrotic syndrome in children is established in the future. We don't know yet, of course, but in addition, routine careful examination by the provider treating the patient's NS is crucial. Lastly, here are the conclusions. I reported a rare case of LCPD or ANFH in a child after long-term glucocorticoid treatment for nephrotic syndrome. LCPD is challenging to diagnose, especially at a young age, because early common signs are not pain. Early diagnosis is essential for a better prognosis of LCPD, and physicians must consider the possibility of this disease. Thus, diagnostic imaging should not be neglected. After experiencing this disease, we cannot totally conclude that steroid therapy and nephrotic syndrome are not related to avascular necrosis of femoral head in children. More case reports and further research are needed. Here are the references. Thank you for listening.